This lecture is being recorded, and then I'll send it to you. Did you guys get the yesterday's lecture? Okay. Hopefully those lectures, when you listen to them, make sure you listen closely. And then especially when I say key things, like it's going to be on the test, make sure you know this, et cetera, et cetera. Anything in red is always fair game for a test. So, all right. Okay, you guys are described the processes involving an infection and how nosocomial infections are acquired. Right off the bat, do you guys know what a nosocomial infection is? What's a nosocomial infection? Say again. What kind of infection? Yeah, hospital-acquired infection. So hospital-acquired infection. And in this lecture, I'll be talking about also laboratory-acquired infection. I talked about that one yesterday, where one of my friends, my supervisor friend, had actually had a fatal incident with a laboratory-acquired infection. Okay, you'll also describe the infection process. Organ systems commonly involved in practically every part of your body. There's no part of your body can be free from infection. The common organisms involved in organ system infections. You list the approaches to diagnosis of infectious diseases. And that's really important because in the microbiology laboratory, and I'm going to mention this later, you guys are actually, you will actually experience how you will be helping out doctors in diagnosing infections. The one main doctor that will be coming to the laboratory is the infectious disease doctor, the ID doctor. He's going to come running first thing in the morning. Is anything growing? Is there anything growing? Especially for joint or knee replacements. One of the things that the ortho docs are really afraid of is if there's like a Staph aureus infection, he'll want to know what's growing, and he'll be the first in that laboratory and say, is there anything growing? So he'll develop a really nice relationship with the staff in microbiology because you have something that he wants. So they're gonna be nice to you. So very helpful in diagnosing infectious disease. You already know what nosocomial infection is. Common organisms involved in nosocomial infection. I'll go over those organisms and the goal of infection control. So humans are germ-free in your utero. So when you're born, you have no bacteria, and it comes later on that your normal flora will develop. You have to have normal flora, okay? Normal flora is beneficial. However, in certain conditions of the body, it can be, these organisms can be opportunistic and can cause infection. So there's a balance in your body that will protect you against infection, but then when that balance is tipped in favor of the bacteria, then the bacteria can cause infection, okay? So there is kind of like a hemostasis, but you're not sick because there is that balance of protection versus the potential for infection. Infection can also be acquired, direct or indirect. As you know, you can pick up things just walking through the mall. You can pick up tuberculosis. You can pick up all kinds of organisms from the environment. So you know, people sneeze on you or you touch things. So you can acquire infections from the environment. Okay, the sequence of events during infection and disease. So there's a reservoir of infection or bacteria that exists. And say, for example, let's say like a cat, for example, and then there's transmission to a susceptible host. Let's say that cat scratches an individual and you become the susceptible host, and the organism that I'm talking about is Pasteurella multocida. You'll know that. You'll memorize this. You'll take it to the board exam. Pasteurella multocida is the organism that causes cat scratch fever. The organism enters the host and then it multiplies because it likes its new environment, and the organism injures the host because the host got sick. Okay, so the development of disease, the first part of the disease is the incubation period, and that's the period between infection, the time that you are introduced to the organism and the appearance of symptoms. So between the time of this foreign organism enters your body to the point where you start showing symptoms, that's the incubation period. The prodromal period is a short period after incubation characterized by mild symptoms such as malaise. So now your symptoms are turning into mild symptoms. Basically your symptoms are getting a little bit worse. And then you have the period of illness. This is when you're really sick. The host will exhibit overt signs and symptoms of disease. So now you're feeling really sick. You got fever, myalgia, sore throat, you're coughing all over the place, and your immune response is trying to overcome this infection. So the immune response usually overcomes the pathogen. If not, then you'll die. Okay. And then after that, once your body overcomes the infection, then there's a period of decline. Signs and symptoms will decrease, but the patient is vulnerable to secondary infection. So you're not totally protected because there may be some organisms. You're just at a point where your body's defenses is your body's ability to protect the body against infection is greater than the ability of an organism to cause infection. Okay, you see the balance is tipped now more in favor of protecting the host. Okay, so once that balance becomes again in favor of the organism, then now you're susceptible to infection. So you guys see that balance right there. So because you have protection and then you have organisms. We have bacteria in our body right now, but because we have a pretty good immune system protection that it's overcoming, it's keeping those organisms in check. Once that balance, again, is tipped in favor of the organism, then now the organism becomes what's called opportunistic, and then it'll cause an infection. Okay. Period of convalescence. Period of convalescence is where the patient regains strength and returns to pre-disease state. But then again, there's still, you need to keep in mind that there's still organisms present that can still cause infection. All right, terminology. Infection is the invasion or colonization of the body by a pathogenic microorganism. And disease occurs when an infection results in change of state from the state of health. And colonization is basically the persistent survival of microorganisms on the surface of the body. Okay, incidence and prevalence. Okay, incidence of disease. Okay, these two definitions sound pretty very, very similar. It's kind of like in hematology, MCH versus MCHC. It took me like 5 times to distinguish between the two. But anyway, incidence and prevalence. Incidence is the number of people in a population who develop disease during a particular period of time. So it's the number of new cases divided by the number of people who can be infected. So incidence is the number of new cases divided by the number of persons at risk for infection. Prevalence is the number of people who develop disease at a specified time, regardless of when it first appeared, or it's the number of cases in a population at a particular time over a particular period. Prevalence is more of kind of like a snapshot. Okay, like I want to know how many people were infected with a hepatitis outbreak in May of 2021. That's prevalence. Was it prevalent during that particular period? Sporadic disease is disease that occurs occasionally. It'll pop up, then it'll go away. It'll pop up and then go away. You must be Dan.
Yes.
Welcome, Dan.
All right, I lost.
That's okay. You got lost?
Yeah, I didn't know. Well, I thought it was over there.
Oh, okay.
I was calling the.
Did the schedule say I'm supposed to be in the classroom? For lecture? Okay. Would you prefer this lecture in the lab? Or do you want to go from classroom then to the lab? I want to answer it for you right now. Let's stay here. You want to stay here and do lecture? You don't want to go into the classroom, okay? All right. But Sray, what did you say? You like it here? Okay. Let me know. Let me know what you don't like. All right. Sorry, I apologize for that, Dan, for the confusion. Okay. Incidence, prevalence, and sporadic disease. Endemic, epidemic, and pandemic. Endemic disease is constantly present in a population in a particular location. Basically, endemic, epidemic, and pandemic is the size. Basically, the difference is the size of the area that's affected. If something is endemic, like for example, we're talking San Diego County. Okay, there was a listeria outbreak in San Diego. If that listeria outbreak turns into, because listeria is one of those organisms that is found in, can be found in dairy products like cheese and dairy products and milk. And if a certain lot number is distributed throughout the United States, then San Diego County can turn into the Western US or almost all the US. So that's when it becomes an epidemic. Pandemic is now when the disease is discovered across different countries. Okay, so that's the difference between the three. An endemic is a small location, epidemic is a larger location, and then when it crosses across country, international, then it's becomes a pandemic. And then you got acute disease versus chronic disease. Acute disease develops rapidly. If you can have a hepatitis infection, so you're infected with hepatitis, you get sick for a couple weeks, and then you recover. So that's an acute disease situation. If you can also have hepatitis where you show infection serologically, you're positive for the hepatitis B surface antigen, and it doesn't go away. In some patients, in some individuals, you can be positive for the hepatitis B surface antigen for almost forever. So, and then you will not recover. You're not going to get sick. And this is called asymptomatic chronic condition. So you don't have any symptoms, your liver functions are fine, but serologically, you're positive for the hepatitis B surface antigen. You're positive for hepatitis. However, serologically, you're still positive and you're positive for a long time. This is called chronic disease. Okay, so chronic, if it lasts for a long time, acute is the duration is short term. Okay, so that's the difference between the two. Okay, systems commonly involved in infections. Again, all these systems: blood, lower respiratory tract. Lower respiratory tract involves the lower lobes of your lung. Upper respiratory tract includes the bronchioles, the throat, oral cavity, and the neck. Central nervous system, your brain, cerebrospinal fluid, your nerves. Above your upper respiratory tract are your eyes, ears, and sinuses. And then of course you have your respiratory tract. Your urinary tract, I'm sorry. Okay, and then you got systems commonly involved in infection. You got your genital tract, the gastrointestinal tract, skin and soft tissues, body fluids, bone and bone marrow and solid tissues. Hopefully I can get culture, I can get examples of cultures where we can actually see growth in the different types of growth patterns. Okay. The organisms involved in organ system infections, blood, if you got a positive blood culture, that's not good. But Staph aureus can be in there, E. coli, CNS, which is coag negative staph. Coag negative staph is staph other than Staph aureus. Okay, so that includes Staph epidermidis and Staph saprophyticus. Those are your coagulase negative staph. The coagulase test is a test to determine whether or not you have Staph epi versus Staph aureus. So you'll be doing what's called the coagulase test. If it's negative, then it's a coagulase negative staph. If it's positive, you don't say coagulase positive staph, you just call it Staph aureus, because only Staph aureus is coagulase positive. That's the only one that's coagulase positive. So you call it Staph aureus. CNS can either be one of two staphs, the Staphylococcus epidermidis and Staphylococcus saprophyticus, okay? And then you have Enterococcus, and Enterococcus, also known as, when we talk about the streps, Enterococcus is a strep. It's a group D strep, okay? Group D streps are broken down into two categories, Enterococcus and non-Enterococcus. And then I'll show you how to distinguish between the two of them. It's a really easy test. Candida albicans is a yeast. Once yeast gets into your blood cultures, that's not good. Pseudomonas aeruginosa. Pseudomonas aeruginosa is not an Enterobacteriaceae. It's one of the aerobic gram-negative rods. And Klebsiella pneumonia can be found in blood cultures. Viridans strep is a strep. That's your alpha strep. You've heard of alpha streps before, right? If you do a respiratory culture, you see alpha colonies. Chances are those are Viridans strep. Okay, not really. It's not really clinically significant if you see it in the respiratory culture. However, there's Viridans strep that can cause problems in your heart, subacute bacterial and endocarditis. It can infect the valves of your heart. So you think Viridans strep, no big deal, right? Viridans alpha strep will throw it away, but don't be so fast because it can cause subacute bacterial endocarditis. Strep pneumonia is very important, causing pneumonia. There's a nice test where you can identify strep pneumonia real quickly, and I'll show that to you. It does have a characteristic gram stain. These are gram-positive diplococci, however, they're lancet shaped, and I'll show you. I'll explain that to you later in the lab. Enterobacter cloacae is Enterobacteriaceae. Proteus species, Proteus mirabilis and Proteus vulgaris are two agents that causes problems in the laboratory because Proteus organisms are swarmers. When they swarm on your culture, especially on blood, then it makes it difficult to isolate any other pathogens that may be present. So if you have Proteus, you need to figure out how am I going to get to that other. It's a given you got Proteus, okay? So you can that's reportable, you'll report it. But you see a colony that looks like a gram-negative rod, which is also important. You need to know how to go after that gram-negative rod without getting contamination from the Proteus, because once Proteus swarms over another colony, there's no way that you can be so skillful that you can get a pure portion of that colony that you're going after. So there's ways to eliminate or get Proteus to not swarm. There's ways to get Proteus to not swarm. Beta hemolytic strep, that includes group A and group B, which are strep pyogenes and strep A galactiae. And then anaerobic bacteria. Unfortunately, I won't be covering anaerobes, the Bacteroides fragilis and the Clostridium perfringens. Those are two main anaerobic pathogens. Okay, lower respiratory tract, urinary, upper respiratory tract, oral cavity, neck, central nervous system, eyes, ears, sinuses, urinary tract, and the genital tract. GI tract, skin, soft tissues, body fluids, bone marrow. Hopefully I can get cultures representative of these various different organ systems. Okay, so when you get a specimen coming into the laboratory, you'll be doing direct examination of the specimens for the presence of pathogens, microscopy. So one of the first tests that you'll be doing is like a gram stain. You get a swab, smear it onto a slide, air dry it, and then do your gram stain. So one of the things I'll be looking at is you guys have all done gram stains before, I'm assuming that, correct? Okay, so when you do your gram stain, what is it? 1 minute crystal violet, 30 seconds to 1 minute of grams iodine, and then acetone alcohol, and then safranin for what, 30 seconds to a minute. Is that correct? Does that sound right? Okay. We're not going to do it that way. I'll show you how to do it the CLS way. All right. So that's direct examination. Then you got growth and cultivation of the pathogens. So once you do your initial gram stain, you want to see what's in the culture that's being submitted. Gram-positive cocci in pairs and chains, gram-positive cocci in clusters. That's a big deal on how you report those. Gram-negative rods, okay? Curved gram-negative claws resembling seagulls, okay? Those are all descriptive terms that the doctor is smart enough to figure out gram-positive cocci in clusters, gram-positive cocci in pairs only, or gram-positive cocci in chains, or gram-negative diplococci appearing to be intracellular. Those key phrases, the doctor is formulating what type of organism is possible potentially in that culture. If you say gram-positive diplococci, diplococci is a term, and you don't report out any chains, gram-positive cocci in chains, and you report gram-positive diplococci only, then he's going to start thinking pneumo. Once he starts thinking pneumo, then he can probably start treating empirically, okay? If you report gram-positive cocci in clusters, then right away he's going to think staph, okay? And then if you say gram-positive cocci in tetrads, there's only one group of organism that exists as gram-positive cocci in tetrads. Anybody know what that is? You will after tomorrow. Gram-positive cocci in tetrads is Micrococcus, okay? Micrococcus. So you're based on a gram stain, you will at least know what group of organisms you're dealing with. Tetrads, pairs and chains, and clusters. Okay, those are gram-positive. So that's basically the gram-positive cocci lecture tomorrow. Okay, so that's growth and cultivation of pathogens. Analysis of cultivated organisms or culture. You do an ID and sensitivity. So you're going to do, there's different systems in the microbiology laboratory. If you don't know right off the bat your gram-negative rod, then there's identification systems available, and they're automated identification systems. And then you're going to be doing susceptibility. Susceptibility testing is a whole lecture. There's two types. You report Kirby-Bauer sensitivity. When I say sensitivity, that refers to Kirby-Bauer. If I say MIC, that refers to serial dilutions. Both of those, the Kirby-Bauer sensitivity and the MIC susceptibility testing, due to two different methods, will give you similar results. It'll tell you the best antibiotic. It'll tell the doctor the best antibiotic that can be used to treat the patient. So if an organism is sensitive or resistant to a certain antibiotic, which would be useful to the doctor, whether or not it's sensitive or whether or not it's resistant? If I tell the doctor that, okay, this organism is sensitive to amoxicillin or it's resistant to amoxicillin, which one would he want to use? That's okay. I'm just seeing if you can figure it out analytically. What do you think, Mr. Jeremy? Hmm? You want to tell him, will he be happy to know if the organism is susceptible to amoxicillin or resistant to amoxicillin? Hmm? No, I didn't hear you, so that doesn't count. Okay, susceptible. Anything with an S, susceptible. Susceptible means that the organism is susceptible or it will die in the presence of that antibiotic. Okay, if an organism is susceptible to an antibiotic or sensitive, so think of susceptible equals sensitive, okay? So if the organism is sensitive or susceptible to a certain antibiotic, then it'll die. If it's resistant, think of it as it has some kind of shield that it's going to survive. We don't want the organism to survive, right? So we want the organism to die. So if you tell the doctor, hey doctor, the organism seems to be resistant to amoxicillin, he's going to say, oh shoot, okay, try another antibiotic. He's not going to want to use amoxicillin if it's resistant, because if you give amoxicillin, that organism that's in the patient's body will not improve. Okay, so the best information that the doctor will need or want is anything that's susceptible to that certain antibiotic. Okay, susceptible. Now, obtain sufficient growth. When you do iodine sensitivity, especially with a Kirby Bauer, you can't just make a cloudy suspension of your organism, put it onto a Kirby Bauer plate, and start adding your antibiotic disc, which we'll be doing later on in the semester. You have to use a standard suspension of organism, and that's using the 0.5 McFarland standard, and we'll be using that. Okay, so you have to have a standard suspension of organism, and then you can do your sensitivity testing. So you'll do traditional cultivation, culture, and ID, but you won't be doing. You can also do nucleic acid testing or immunochemical testing or serologic techniques. Usually in the basic microbiology laboratory, you'll be doing traditional cultivation of ID and ID. Okay, infection, nosocomial infection. That's where you check into the hospital and you don't have any evidence or any sign that you have any kind of infection. You're just in the hospital because you want to, I don't know. I don't know. You have to do something. I don't. Let's see. I don't know. Something unrelated. Something a simple procedure. Okay. Now, after a couple of days, you stay in the hospital after the surgery. Then it turns out that you develop a fever. Okay. Well, you didn't have a fever when you came in, and as it turns out, the fever. They do blood cultures or they take cultures, and then they find an organism that is causing you to have an infection. So now your length of stay is longer. And I talked about length of stay yesterday. So your length of stay is longer. That's why nosocomial infections are bad. And so a nosocomial infection is an infection that you pick up while you're in the hospital, not before admission. Okay, it's very expensive when you have a nosocomial infection. These are old numbers, 4.5 to 15 billion annually, $1 billion annually to healthcare, and increased mortality and morbidity adds days, a week to 2 weeks of hospital stay. So that's not good. That's what the infection control nurse is. That's her primary job, is to get a handle and prevent nosocomial infections, the infection control nurse. The most common nosocomial infections are urinary tract infection, pneumonia, surgical site infections, and bloodstream infections, positive blood cultures. Higher rates in large hospitals and small community hospitals. Okay, factors that determine likelihood of infection. Susceptibility of the patient to infection. If you're immunocompromised, so if you, and those include like patients over 80 years old, the elderly or the newborns, those two categories of patients are susceptible to infection. The newborns haven't developed their immune system yet, and the elderly, their immune system has become weaker. The virulence of an organism. What virulence means is, say, for example, you have regular E. coli in your gut, that's not a problem. But if it becomes virulent, a virulent organism, that means it's aggressive. Virulence means it's the severity of harmfulness. Okay, that's what virulence means. How aggressive the organism is to cause infection. Okay. So if you have a virulent organism, then you have a higher likelihood of becoming infected. The nature of the patient's exposure to the organism. So if you have, so for example, Brucella is an organism, and a lot of in the industrial community, meat handlers, butchers, people who work in farms and slaughterhouses, they are exposed to the raw meat of the animal. So as opposed to somebody working in an office downtown, okay, so they're not exposed to those organisms. So the nature of the patient's exposure to an organism makes them a high likelihood of becoming infected, okay. Organisms involved in most nosocomial infections: Staph aureus, co-negative staph, Enterococcus, your gram-negatives, Clostridium difficile, that's an anaerobe of funguses, and other gram-negative rods like Acinetobacter. That's a we'll be talking about Acinetobacter. That's one of the organisms. If you're infected with Acinetobacter, it's difficult to treat. It's a very resistant organism. Citrobacter and Haemophilus. We'll talk about identifying Haemophilus. Goal of infection control, designed to detect and monitor hospital-acquired infections, and that's why hospital have what's called infection control committee. The infection control committee includes a microbiologist, that's usually the supervisor of the microbiology department, infection control nurse, infectious disease doctors, and pharmacists. So infection control committee. So there was one time when I was stationed in Guam, they were forming an infection control committee, which didn't have a microbiologist in it. And one of the things about Guam was that one of the things that they need, and it is that it's called an antibiogram, and that comes from the pharmacist. An antibiogram is where you take all the organisms isolated in the microbiology department and you look at the sensitivity patterns. So for example, you look at a whole year's worth of data, and let's take one organism, E. coli. If you identified 280 E. coli was identified 280 times. You look at the sensitivity pattern. How many times was it sensitive to a certain antibiotic, and how many times it was resistant to certain antibiotics? So what you do is you have to do a percentage of sensitivity and a percentage resistant. And for each organism that was identified in that department, you provide the likelihood of an organism being susceptible or sensitive or resistant. And of all the organisms identified, you produce this report, and that type of report where, say for example, okay, I identified Kleb pneumo this week on certain organisms. I'll go to that antibiogram, and Kleb pneumo at Naval Hospital Guam, and it says, okay, every time Club pneumo, the likelihood of being resistant to ampicillin was 80%. So that would be a good antibiotic to use. But if I go to that organism and I see that it was 30% sensitive to penicillin, for example, then I won't use penicillin. So the antibiogram is a very important tool that the inpatient, the doctors would use if once you see that you identify an organism. So that's the importance of having a microbiologist who can do reports like that. Okay, Infection Control Committee is gathering information during an outbreak. If you keep an eye on what's been going on with COVID, then you can see how it's interesting how the availability of information actually changed. And I think it's really, this whole thing is really political because during one administration, the CDC and whoever was always reporting the death rates of certain organisms. And then once the administration changed, whatever happened to death rates, you know, it's like, wow, we don't know what the death rates are. In fact, they want to give vaccines to children ages 5 to 12. Well, why do they want to force vaccines on children 5 to 12 when they essentially have a 0 death rate? They were really, really pushing the vaccine. So I don't want to get political here, but that's why you gather information. It's important to know death rates and the population, how it's affected during any kind of outbreak, like a pandemic or epidemic. Microbiology provides information, ID and sensitivity and characterization shows evidence of nosocomial infection. And then more on preventing infections on page 1094. Okay, quality control. Quality control is important no matter whether or not you're microbiology, chemistry, hematology. You always want to be in control. We'll identify and design quality control program. The goal of QC, describe strategies for proper quality control program, and governing bodies. The governing bodies that tell us how to set up our QC program. So quality control is, the goal of quality control is that you want to make sure that the results that you are reporting are accurate. And in order to do that, that's why you run QC. So QC, if you run QC and if you're within acceptable limits, then you have pretty good assurance that the result that you're reporting, whether it be in hematology, chemistry, or wherever, microbiology, that your results are accurate. Okay, and this provides quality patient care. So quality is the basis of healthcare excellence. It's a platform that combines all the elements of structure, process, and outcome. Basically, the bottom line is you want to be providing results for high quality patient care. Okay. In the past, QC was a small segment in the laboratory, and it's replaced by a total quality program. So quality, not to say that QC has gone away, it's just expanded into what's called total quality or quality assurance. Quality assurance is more encompassing. It not only includes you know, the QC in the laboratory, but includes other things like adequate training, instrument maintenance, downtime of instruments, you know, in microbiology, contamination rates. You don't want a high blood culture contamination rate. If you do, then there's something wrong in the blood culture process that needs to be looked at. Usually a blood culture contamination rate, you want to keep it around 2 or 3%. So that's quality assurance. You want to, so it's a little bit more, it's a little bit more broad rather than doing QC in testing in the laboratory. So that's quality assurance. So that's TQM, and TQM is equal to TQL. TQL in the military. TQM is the same as quality assurance. You do continuous quality improvement. You always want to look at your processes and look for areas of improvement. Okay, especially with new technology that comes out, you're always going to be improving. Like I said, laboratories in the near future may be turning to PCR technology. Okay, so these procedures that you're learning now can be evolving and can be replaced by PCR technology. Process improvement, that's another thing that you're looking at new technology or better ways to do things. Okay. Looking at instruments that provide faster turnaround time, looking at instruments that can count reticulocytes, for example, a better way of reporting reticulocytes or nucleated red blood cells. There, in the past, about 10, 20 years ago, NRBCs are only detected on the smear review. Now you have instruments that can actually detect the presence of nuclear red blood cells and reticulocytes rather than going to the manual smear. So that's process improvement. It's done because those procedures have now become automated. Okay, so the goal is to reduce length of stay. You don't want an extensive length of stay for patients in the hospital because it's expensive. You also want to improve turnaround time for results because the lower the turnaround time that you produce your results, then that can positively affect the patient's length of stay in the hospital. And change to the appropriate antibiotic. So if the patient's not responding to a certain antibiotic, the doctor can empirically, meaning that based on his past performance and the patient's symptoms, he can go ahead and prescribe an antibiotic. But if the patient's condition doesn't change, then he can change to the appropriate antibiotic. And customer service, you always want to be nice to the patient so that they'll tell their friends that I had great experience at Sharp, or I had a great experience at Scripps. That way, the next time you're sick, then you can tell them, I want to go to Sharp or Scripps. Customer satisfaction. TQL, total quality program, must include proper specimen collection and transport, SOPs, personal qualification, reference lab, patient reports, and proficiency testing. So these components of a total quality program are actually areas in the laboratory that CAP inspectors look at. Okay, are you guys familiar with CAP inspections? CAP inspections. Okay, so if you are responsible for the lab general program, or which is the general portion of the laboratory, or if you're a section supervisor, they're going to take a look at your specimen collection and transport procedures. Okay, they want to see that your SOPs are current and up to date and have annual review. Personal qualifications to make sure that every person in your department has current training. Reference laboratories that you send your specimens to are adequately accredited, and patient reports need to be easily readable. And you have to be on a proficiency testing program, like doing CAP surveys periodically. Okay, this is what inspectors look for, and they want to look for, especially in the proficiency testing, to see if your scores are 100% or 80%, and if not, then you have to have corrective action documentation. Okay. Performance of checks on instruments is what they'll also look for. Maintenance and QC records, a QA program where you look at pre-analytical testing, analytical testing, and post-analytical testing. Pre-analytical is like blood drawing and processing of the specimen. Analytical is actual testing and looking at the QC, and post-analytical is how long you keep specimens if you have to do an investigation in your refrigerator. Participation in an internal or external audit program. You can have, like if you're in a Sharp system where you have different Sharp hospitals in the county, you can have other Sharp hospitals come into your laboratory, kind of like and do a peer review. So let me see, Sharp Chula Vista can go inspect or do what's called a technical assist visit, at Sharp in Linda Vista or Sharp at Grossmont. And then the section supervisor has to do continuous daily monitoring, okay, making sure that everybody is doing testing, they're not on their bench reading books or smoking cigarettes or whatever. Okay, regulatory authorities in microbiology, CLIA. CLIA is the agency that governs the federal regulations. They are the ones that define high complexity testing, which is the level of testing CLSs do, moderate complexity testing, which is what the MOTs do, and wave testing, which is what the nurses and non-laboratory personnel do. CDC is the Center for Disease Control. They write the regulations for enforcement of CLIA. CMS stands for the Center for Medicaid and Medicare Services. And CMS is important because they're the ones that reimburse hospitals for taking care of the homeless and patients over 65, the elderly and homeless. Medicare, which is over 65, and Medicaid used to be called Medi-Cal. So those are the low-income patients. The FDA I talked about yesterday clears products used in the diagnostic testing. Every test in the laboratory has to be FDA approved. Okay. EPA, when you see EPA, that's environmental. They'll take a look at your waste disposal. OSHA is safety. They want to make sure everybody has to be safety trained. When the Joint Commission inspectors come into your laboratory, they look at two things. They look at your safety training and your competency. Okay, so safety training is really important. OIG stands for the Office of the Inspector General, and they monitor fraud, waste, and abuse, like Medicare fraud, billing Medicare. They want to make sure that that doesn't take place. It used to be, I don't want to say it's common, but it happens where people would charge for Medicare. They would get reimbursed when it was actually fraudulent. The patient didn't exist. Sometimes that kind of stuff happens. All right, specimen collection and transport. Okay, design a system, sure. Okay, types of specimen collection kits, that's what we'll do. Appropriate collection kits, strategies for proper specimen management. Okay, blood cultures, okay. 962 in the book. Different types of blood culture systems. You want, that's the specimen that the doctor will ask for if you have running a fever and you're suspecting septicemia. Okay, that means you have a positive blood culture, and the collection is different between adults and children. 10 to 20 mLs for blood collection for adults, and for children, it's usually about 5 to 10 mLs, but it could be different from lab to lab. Usually they want to do 2 to 3 collections at different times, blood culture ×2 over 3 days, things like that. The lower respiratory tract is your deep respiratory tract, submitted in a sterile container. Expectorated sputum or induced sputum, that's a type of specimen. A bronchoscopy, aspirates, fluorocentesis, and biopsy. Those are all the specimens of the lower respiratory tract. The upper respiratory tract, it's a little easier to collect, submit those specimens in a sterile container or different tip swabs. Okay, that's the respiratory tract and urine specimens are the two common specimens received in the laboratory. CNS, that's CSF, cerebrospinal fluid. Those are processed stat. The different tubes that you receive, tube 1 is chemistry, tube 2 is for culture, and tube 3 and 4 is for hematology. You don't want to refrigerate these. Actually, you might want to incubate them because if you incubate it and something grows, that's important to know. And then you can get eyes, ears, and sinus specimens. Again, submit those in a sterile container. And obtain material from the specific site. And then urinary tract specimens. So you got a clean catch midstream, you got a catheter, and then you got a bladder aspiration. Those three urine collection sites is the level of sterility. So clean catch, you don't want to do first catch. You want to do midstream clean catch urine. That's what CCMS is. And then the next sterile, it's more sterile, is a catheterized urine. Okay, and the most sterile is a bladder or a pubic aspiration. They usually can do those in babies. Okay, so with a clean catch urine specimen, there can be a high likelihood for contamination. And as you go from catheter to bladder aspiration, the likelihood for contamination is less. And then the genital tract, submit those in a sterile container, and the specimens will come from the urethra and the vaginal surgical area. Okay, the GI, gastrointestinal tract. For stool specimens, the transport media is Kerry Blair. And I'll talk about that Kerry Blair when I'm talking about the Vibrio cholera. Miscellaneous specimens, duodenal aspirates, and the string test. The string test is a test where you actually take this gelatin capsule, for gelatin capsule, and attached to this gelatin capsule is a string on one end. So you'll tell the patient to swallow the capsule part, but make sure you hang on to the string, and it's taped to your cheek, and you have the patient wait 6 hours or overnight. Okay, so the string is taped to the patient's cheek, and then at the end of 6 hours or the next morning, what'll happen is they'll start fishing out the string, and at the end of the string, what they're looking for is a parasite called Giardia lamblia. Have you guys heard of that? Giardiasis. Okay, so this is the string test. You're actually fishing for the parasite. Okay, so you pull at the string, and then you examine the end of the string for the presence of Giardia. So when we get into parasitology, it's one of the easier parasites to recognize, and I'll show you why. Okay, it's a neat test. So that's the string test for Giardia. Skin and soft tissues, submit in a sterile container. The best culture material is actual material from the site. Okay, for skin and soft tissues. Okay, same for body fluid, bone and bone marrow, and solid tissues. Submitted in a sterile container, of course, and the best specimen is actual, as opposed to a swab. You know, they can swab that specimen or submit the actual specimen to the laboratory. Actual specimen is the best specimen. Proper specimen management, appropriate collection techniques. You want to on the early phase of the disease, of the illness, that's when you want to collect the specimen, because that's when the organism is the most active. Clinical material is preferred over swabs, and I just mentioned that. You want to do cultures from the actual clinical material. For specimen transport, it's better to transport the specimen within 2 hours, okay, in a leak-proof sterile container. Specimen preservation, like PVA, polyvinyl alcohol. For stool, formalin. They don't use formalin anymore, and PVA because it has mercury. But we'll talk about stool collection procedures. There's holding media like Stewart's, Amy's, and I mentioned Kerry Blair already. Specimen storage, refrigerate, freeze, or body temperature. Specimen labeling, no matter what department you're working for, is whenever specimens come to the laboratory, you need to have a specimen rejection policy. If it's mislabeled, if the name on the paperwork doesn't match the name on the specimen, then that's a possible specimen labeling incident. If the specimen comes to the laboratory unlabeled, that's another reason for rejecting a specimen. You should never receive a specimen or do testing on a specimen that was unlabeled. And if you have a specimen, and this is already days later, where a patient will call the laboratory and says, well, I got a notice that I got a throat culture or a urine culture or a pap smear, and I got results in the system. Well, you know what? I haven't been to, and she says, well, I haven't been to the laboratory in 6 months. So that's also a possible specimen mislabeling issue. These are, specimen mislabeling issues. You're potentially harming the patient. Like, for example, a pap smear. You have a patient who has been diagnosed with ovarian cancer, okay? And she's been monitored by pap smears, and the pap smears obviously are positive, will have positive cells for the ovarian cancer. So you take that specimen and it comes to the laboratory and you get the labels mixed up, and your label all of a sudden accidentally gets put onto that specimen. How would you like it if your doctor now tells you, I got results from your pap smear and it looks like you got stage 2 cancer? Okay. So that's why, it's like I went to a meeting where pap smears, the nurses, and I couldn't believe this, the nurses were saying, why do you always reject specimens, mislabeled specimens for pap smears? Well, that scenario that I just gave you, well, how would you like to find out if your pap smear was mislabeled with a patient who actually has stage 2 cancer? Would you accept that? The answer is obvious. So specimen labeling or specimen mislabeling is a very, very important issue. Specimen requisition, again, you got to make sure that they write the correct information, like left lower lobe when it's actually the right lower lobe, things like that. You got to make sure that the nursing staff correctly labels the specimen, and the same information corresponds to the information on the paperwork. And then there's a rejection criteria, and that's on page 71. Specimen processing, site specific. Make sure that on the paperwork and on the specimen container, they correspond. You do gross examination, ensures best chance for recovery. Like urine specimens, you want to make sure that it's yellow, cloudy, make sure you have the correct observation. Direct microscopic exam determines the quality of the specimen. For example, sputum specimens for respiratory culture. You can do, you have to screen sputum specimens for respiratory culture by doing a microscopic examination and looking at the number of epithelial cells. If there are more than 25 epithelial cells that you see microscopically, then you don't have sputum, what you have is saliva. Okay, so that's a rejection criteria. So you screen for sputums. If there's too many epithelial cells, it's saliva, you have to reject it and request a new specimen. Okay. Otherwise, you're wasting your media and the time it takes to do the culture. And then selection of media, nutritive, differential, selective, backup broth. So for typical cultures, it's blood chocolate McConkey or blood CNA McConkey, and then you have thioglycolate, the broth media. So those are your typical media when specimens are submitted for those routine specimens. Specimen preparation and the specimen is test specific. So that type of, on the plate in the middle, when you have the back and forth like that, that's the type of streaking for urine. Did you guys know that? Okay, that's for urine. And one colony is equal to 1,000. So if if it fills up the plate, then you have, but it's greater than 100,000 colonies per ml. So that's how you inoculate for urine. And then the one on the right is for regular culture, whether it's a wound, respiratory, that's how you streak for culture. And then the incubation, it's either at 37 degrees or for respiratory, it might be 37 degrees with CO2. One of the things I wish we had here was a CO2 incubator. That way we won't have to use the candle jars. And there's some hyperlinks there that you can try to open. I tried to open some of them, I had trouble, but if you try to open them, then hopefully you'll have success. And that's safety lecture 2. Okay, are there any questions? Okay, no questions. Okay, so we did safety and safety. So tomorrow, now we're gonna start doing organisms. We're gonna start with Micrococcaceae. Micrococcaceae includes Micrococcus, Staph aureus, Staph epidermidis, and Staph saprophyticus. It's a nice, easy section to start with. So we'll be doing that tomorrow. Okay, so for today in laboratory, I have set up 10 gram stain unknowns. Okay, 10 gram stain unknowns, and I have a worksheet here. Everybody come up and take one later. So unknowns 1 through 10. What you'll be doing, and you have until tomorrow to finish this, or you can do it today if you like. You'll be setting up gram stains on each of the 10 tubes, okay? And each of the 10 tubes has 2 organisms in it. So you'll do a gram stain on each of the 10 tubes. Also, too, from each of the 10 tubes, you'll be subculturing to a blood agar plate and MacConkey, and we'll see what grows. And you will report what you see, what you observe on the blood agar plate and on the MacConkey. And then down below on this worksheet, I have how you need to report the gram stain. Gram-positive cocci, gram-positive cocci in clusters, gram-positive cocci in pairs and chains, gram-positive cocci in tetrads, or gram-negative rods. And then for the media on the blood agar and MacConkey media, then I have how you're going to report. On the blood agar, you're going to let me know if you see white colonies, gray colonies, yellow colonies swarming. And then on MacConkey, you're going to report whether it's a lactose fermenter or a lactose non-fermenter. Do you know what they look like? What does the lactose fermenter look like? Okay, lactose fermenter is pink. Okay, so we're not going to use the word pink. You guys are going to be microbiologists. You see pink cultures, don't say, I got pink cultures. You say, these are lactose fermenters, okay? If it's colorless, then it's a lactose non-ferment. It's a non-lactose fermenter. Colorless is a non-lactose fermenter. I have it here on your worksheet. And then on the lactose fermenter, there's 2 types of lactose fermenters. Either it's going to be a mucoid lactose fermenter, a mucoid pink, or it's going to be a flat, dry pink. Okay, so those are the 2 morphology types of the lactose fermenters that you will, hopefully you'll see. Okay. All right, come up and get a worksheet.